Okay guys, let's start breast pathology. First, I will talk about the anatomy of the breast. You need to know about the structure of the breast before you learn the diseases associated. So first we'll draw the breast outline. And then we have the muscle layer. This is the fascia. This is the pectoralis major muscle. Behind this we have another layer of fascia. And we have the ribs. And between these you have the intercostal muscles. Here's the pectoralis muscle. Next, we'll talk about the breast structures. So what's important for us is going to be this area, the drainage area is called the sinus. Here are the ducts which connect to different lobules. So let me just draw it like this. These are lobules. Now what's important to understand is, these are ducts, these are lobules, breast lobules. Here's the sinus, breast sinuses, and they open to the nipple. Okay. Next we have the fatty tissue, the adipose tissue. You find it all over the breast. And also we get suspensory ligaments which hold up the breasts, which give the tightness to the breasts. The suspensory ligaments. This is the nipple. And these ducts open to the nipple. Next, I will talk about the lymphatic drainage of the breast. Okay. So we have two breasts, the left side, right side, and the main lymphatic drainage is going to be the axillary lymph nodes. Okay. The main lymphatic drainage will be to the axillary. So around 75% of cancers will metastasize to the axillary lymph nodes. Okay. And next, right next to the parasternal, the sternal bone, we have the parasternal lymph nodes. There's also going to be communication between the two breasts. Okay. And then we also have supraclavicular lymph nodes. We have inferior phrenic lymph nodes. But for us, the main things we need to know are these three. The fact that tumors can spread to the axillary lymph nodes most commonly, or the parasternal lymph nodes, or the contralateral breast. Okay. So that's the basics for the breasts. Now we will start the diseases of the breasts. Okay. First, I want to introduce you to a word which is called mastitis. M-A-S-T-I-T-I-S. So what does mastitis mean? It means inflammation of the breasts. Okay. This is usually due to an infection, especially in women who are breastfeeding. Okay. Mastitis is an inflammation of breast. It's usually due to an infection, especially in women who are breastfeeding. Okay. Next, we will talk about breast carcinoma. Now, breast carcinoma is the most common carcinoma in women and is the second leading cancer death. Okay, so what is the first leading cancer death? It's lung cancer. Second leading cancer death is breast carcinoma. The main point I need you to remember when it comes to breast carcinoma is it is associated with prolonged exposure to estrogen. Okay, associated with prolonged exposure to estrogen. So what are the risk factors? Female gender. Obviously, there's a prolonged exposure to estrogen in women. But also remember, males can develop breast cancer. Okay. Post-menopausal women. Breast cancer usually occurs after menopause. And early menarche and late menopause. Why is this important? Because these women are exposed to estrogen for a longer time. Okay. Obesity, because the fatty acids, the free fats, are converted to an estriol compound. That is basically a estrogen analog compound. Okay. Atypical hyperplasia and first degree relatives with breast cancer. So if you learn genetics, you should know first degree relatives are either your mother, your daughter, or a sister. Okay, so that is the risk factors for breast carcinoma. Now we are going to learn the classification of breast carcinoma. Okay, I hope you understand the anatomy behind this, because carcinomas are going to be either from the lobules or the ducts. Okay, so the carcinomas are going to be either from the lobules or ducts. Let me take just one lobules. Okay, and one duct. And remember, in women it is more common to have carcinomas above, because in men usually you get the carcinomas just below the nipple. Okay, and because of this, males will also have discharge. Okay, in women the most common location is usually above. In males you get it just below the nipple, and there is commonly associated discharge from the nipples. Okay, so first I want to draw the outline. Okay, first of all, we can get a carcinoma in the ducts. Okay, give me a second. Ductal carcinoma in situ. What does that mean? Here is the basement membrane. It does not penetrate into the basement membrane. So the first type of carcinoma is called ductal carcinoma in situ. Okay, so it can grow into the duct lumen like this, and since the blood supply is going to be here, the blood supply will be here. So what happens is, this region, the carcinoma cells will not get enough blood. Okay, so what happens then? Those will die. Okay, and that will lead to necrosis plus dystrophic calcification. Okay, remember I told you there's two types: malignant and dystrophic calcification. Okay, so that is the first type. And the thing you need to know next is, this cancer cells, they can go along the duct to the breast, the skin of the breast, the nipple, and this is a condition called Paget's disease. Okay, this is a condition called Paget's disease. Okay, this is a complication of DCIS, ductal carcinoma in situ. Next, the carcinoma can invade. Okay, this is called invasive ductal carcinoma. Now understand, we are talking about cancers either in the ducts or in the lobule. If it is a ductal carcinoma, the carcinoma can be an in situ carcinoma. It will grow within the gland, within the duct. And if it spreads to the nipples, it is called Paget's disease. If it invades the basement membrane and goes into the underlying tissues, it's called invasive ductal carcinoma. Same concept applies here. We have lobular carcinomas. Look at the difference here. I'm not drawing them touching each other. Okay, that is important for a reason. I'll come to that. These are lobular carcinomas. These can also invade into the outside the lobules, and these are called invasive lobular carcinomas. Okay, so what I need you to understand from this is, basically we have two locations in which carcinomas can occur. One is the ducts, the other one is the lobules. And if either of them invades, we call that invasive carcinoma of the duct or the lobules. Okay, if it goes to the breast, if the ductal carcinoma goes to the breast, it's called Paget's disease. Okay, and why did I leave space here? Because in lobular carcinomas, there is a genetic defect in the protein that encodes E-cadherin. Okay, and when there is no E-cadherin, the cell to cell attachment is gone. Okay, so this connection is gone now. So you find it diffusely spread across the epithelium, not touching each other. That's the first part, the introduction to breast carcinoma. So next we'll talk about the ductal carcinomas. Okay. First, ductal carcinoma in situ. DCIS, ductal carcinoma in situ. Okay, first, there's no invasion of basement membrane. That's the first thing. Okay, next you get calcification. I talked about this. So there's going to be calcification here, and that is what you will find on mammography. Okay, when you do a mammography, you will find calcification. Let me write it as detected as calcification on mammography. Okay, next I will talk about the types of it. First, let's take the version in which some cells travel along the duct to the nipple, to the skin of the nipple. This is called Paget's disease. Okay, this is important. In Paget's disease, you get two things. You get the nipple ulcerating, nipple ulcers plus erythema. Okay, so if you look at the nipple, you will see a certain region of the nipple red. Okay, that is because the tumor cells will come along the duct to the nipple. So these tumor cells will come like this to the nipple. Okay, and you will get reddening plus ulceration. Okay, next, it is, remember, if you get Paget's disease, if you get the nipple ulcers and erythema, it means there is a carcinoma. There is a ductal carcinoma present. Okay, there is an underlying ductal carcinoma present. That's why you get Paget's disease. Okay, next we will talk about the different types we get within the ducts. Okay, first I will talk about the Comedo type carcinoma. So I'll write it as Comedo Carcinoma. Okay, that's the first type. It has central necrosis and calcification. Okay, the next type is a solid type. Okay, let's take a smaller duct now. This is solid type. Okay, it has covered the entire duct. Okay, no central necrosis, but you get a filled duct. Okay, next we have cribriform type. Where we get a lumen, but there are gaps. Let me show it to you. Cribriform type. So this would be the lumen, but you get these spaces between the tumor cells. Okay, and next we have the papillary type. So here's the lumen. If you look at it, you will see ingrowths, papilla. Okay, that's the 4 types of ductal carcinoma in situ. Okay, now we are going to talk about its invasion. Okay, invasive ductal carcinoma. Okay, IDC. Okay, so what you need to know is it forms duct-like structures. It forms duct-like structures on desmoplastic structures. Or tissues. Okay, and this is present as a mass on a physical examination or during mammography. Okay, so you do the physical examination, you do the 4 quadrants like this, you do a physical examination and you find a lump. Okay, that lump is usually found in cases of either benign masses or in cases of invasive ductal carcinoma. Okay, present as a mass on physical examination or mammography. Okay, next we get these situations seen in the nipple: dimpling of skin, retraction of nipple, or fixed to chest wall. Okay, you can get these kind of situations. Okay, we need to talk about the subtypes for this. Don't worry, there's just 3. The first subtype is called the Tibula Carcinoma. So like I said, it forms duct-like structures. So let me see if I have an image here. No. but basically this will form tubule-like structures in the breast tissue. It will have tubule-like structures in the breast tissue. It's all cancerous cells here. So what you need to know is this has a good prognosis. Okay. Next, we have mucinous carcinoma. As the name says, it's tumor cells growing within a mass of mucus. Okay, and again, it's like floating inside this mucus layer. So this also has a good prognosis. It can't move around. And next, we have the dangerous type. This is inflammatory carcinoma. Okay. What does inflammatory carcinoma mean? First of all, these patients could present similar to mastitis. Okay. So these patients will present with edema, basically the inflammatory signs of the breast. Okay, plus highly erythematous. So what do these words mean? Edema means it's like swollen. Okay, and it looks red, highly erythematous. Okay, so these patients will come. Okay, the problem is you might assume it's just mastitis, and you will give an antibiotic and tell the patient, drink it, you'll be fine. But the thing is, you need to always do a follow-up, okay? Because in mastitis, the antibiotics will work, okay? But in inflammatory carcinoma, when the patient comes back, it's still there. And the problem in this is, these tumor cells will go, these tumor cells block lymph nodes, okay? They embolize the lymph nodes. And what does that mean? It's going to spread all over the body. This is a tumor type which has very poor prognosis. Okay, these patients are highly likely to die, and I will show you an image of the tumor cells in the lymphatics. Okay, you can see these will spread either to the axillary lymph nodes somewhere, but these patients have very poor prognosis. And here is an image of inflammatory carcinoma. The reason I wrote it like this is you need to differentiate between mastitis or inflammatory carcinoma. Okay, and I told you how to do that. Next, we have the lobular carcinomas. Okay, lobular carcinoma in situ and the invasive type. Okay, now this is a malignant, nothing to memorize, malignant proliferation of cells in lobules. Okay, and again, lobular carcinoma in situ, I'm talking about the first one. Let me put the topic here, LCIS. Okay, this one, there's no invasion of basement membrane, that is obvious. Okay, and this thing, it's discovered incidentally. Okay, you do an examination for something else of the breast and you find this. Okay, there's no mass or no calcification. Okay, and like I said, cells lack E-cadherin, so they are not glued together. Cells are not glued together. Okay, this is due to the lack of E-cadherin. Okay, and these carcinomas are often multifocal and found bilaterally. Okay, often multifocal, and found bilaterally. What does this mean? We take the breasts, okay, the two breasts, and usually we'll get different foci. It could be here, it could be here, different foci, and it will be bilaterally found. The other breast will also have the carcinoma. Okay, remember we are talking about carcinoma, and that is epithelial cell cancers. Okay, and the treatment, the way you treat these patients are you give an estrogen inhibitor. Okay, tamoxifen is given. It's an estrogen inhibitor, and you follow up. Okay, you don't cut out the tumor, because the main reason, it has a very low risk of developing invasive carcinomas. Okay, it will be present, so you do not cut out the breast, you give tamoxifen and follow up. Tamoxifen is an estrogen inhibitor. Okay, no excision. Okay, low risk of developing invasive lobular carcinoma. Okay, next we talk about invasive lobular carcinoma. Okay, okay, invasive lobular carcinoma. This invades the surrounding tissue. Okay, these will invade, and look at this. I drew it as a single line. We get these cells present as a single line. Okay, these cells occur as a single line. And like I said, there is no E-cadherin molecules, so these cells will look more like this. Okay, we'll see it on histology, but basically it's not going to be a type of tumor like this where there is a connection with each other. Okay, and this will easily metastasize. Okay, next, before I go into the histopathology, I will talk about the Tnm classification. Okay, Tnm classification of breast carcinomas. So first we have the T, that is tumor size, N lymph node involvement, M metastasis. So metastasis is the most important thing to find out, but usually before that happens, we find the lymph node involvement. Okay, metastasis is most important, but the next one is what we can actually do: lymph node involvement. Okay, so how do you do this? You do it with a technique called Sentinel lymph node biopsy. How do you do that? You have the breast here, and we have its drainage to the axillary lymph nodes. Okay, so what you do is, okay, one thing you need to know, the axillary lymph nodes are present as layers. Okay, so if you are to just do a biopsy, you will have to remove all these layers of the axillary lymph nodes. We don't do that. Instead, we do this sentinel lymph node biopsy, where we put a blue dye, we inject a blue dye and allow it to pass across the tumor. Okay, and then it is going to be taken up by the cells. Now we can see these lines properly. So what do? You take out the first line. Take out the first line. The first line for biopsy. Okay, if it is negative, if there is no tumor, then fine, the patient doesn't have any cancer, because it has to first go to the first group. You assume that, okay, it has to first go to the first group before it goes to the next groups. But if it is positive, you remove all the lymph nodes, and we consider N to be positive, or if it has metastasized there, when more than 4 auxiliary lymph nodes are affected. Okay, and next we have something called predictive factors. Okay, what do you mean by that? Predictive factors. This is the risk of developing cancer. Okay, so we take these cells and we search for these estrogen receptors or the progesterone receptors. So if there is estrogen receptors are present, that means tamoxifen will work. It will help inhibit the growth of these cells. Okay. The other one is by doing genetic screening. What do you mean by that? This is a prophylactic. That is, before the onset of the disease, you take measures to prevent it. Okay, this is a screening process in which you look for the BRCA. Let me write it in the center. BRCA1 or the BRCA2. Okay, so you will learn this for genetics, but before that, if the BRCA1 gene is abnormal, it indicates a high risk of breast and ovarian carcinoma. Okay, if the BRCA2 gene is abnormal, it indicates that there is a risk of breast carcinoma in males. This is important, and remember this: male breast carcinomas are rare, but it is way more malignant than in a female, because a female actually has breast tissue which serves a function. Males do not. So these cells, the only function will be growth. Okay, so the type of carcinoma is invasive ductal carcinoma. This is more common. Okay, and there will be nipple discharge. I talked about that. And this is associated with BRCA2 and Klinefelter syndrome people. Okay, so I need to tell you something about this genetic screening. Angelina Jolie, she has a family history of breast cancer, or she did a genetic screening and she found out she's BRCA1 positive. So what did she do? She did the prophylactic treatment. What is the prophylactic treatment for? If you know that you have a risk, you remove the breasts. Okay, prophylactic mastectomy. Okay, prophylactic mastectomy. Okay, you remove the breasts. And remember, just because you remove both the breasts doesn't mean that the risk is zero. There's still a risk. Okay, now that's it for breast cancers. I need you to know one more word. This is called pure. I cannot pronounce this one. Pure d'orange. Okay, this is a type of situation in which there is going to be edema. There's going to be edema, and the breasts will look orange in color. There's going to be, it looks like an orange. Okay, the texture and everything, there's going to be dimplings. It will look like an orange. This is called pure d'orange, and usually you get it with edema in the breasts. You get it in different situations. Most seriously, it will be due to carcinomas. Okay, breast carcinomas. Next, the types of carcinomas. I will give a brief summary again. Breast cancers can either be due to the lobule or the ducts or the lobules. It could be carcinoma in situ, or it can be invasive. That's it. And if it is in the ducts, there is a risk that it can spread to the nipples, the skin of the nipples, leading to Paget's disease. Okay. And different types of carcinomas. The first one, if the carcinoma cells grow too big and they lose their blood supply, they will die, and you get the calcification here. This is called Comedo Carcinoma. This, you can see the lobule is fully filled with the ductal carcinoma cells, cribriform, and you cannot see any invasion. You cannot see it has spread inside. Okay, cribriform, I talked about it. Basically, you get gaps between the carcinoma cells. And papillary ductal carcinoma, self-explanatory. Then Paget's disease, if you look carefully, you will see these cells, these abnormal cells. They are coming to the skin of the nipple. Okay, they are coming upwards. You get it diffusely sent. Okay, and ulceration plus edema. Ulcers plus edema. Okay, here's a ulceration and edema of Paget's disease. Next, lobular carcinoma. Look at this, you can tell it immediately. Here's a lobule, it's full of cells, and if you look carefully, they are not touching each other. There's no communication between each cell. Okay, then we have the invasive lobular carcinoma. Like I said, they grow in a single file between collagen fibers. You can see the collagen, you can see the single file. Okay, and look again, there's no touching. Okay, ductal carcinoma in lymphatics is a lymph vessel, and you have the carcinoma forming an emboli. This, you need to differentiate between mastitis or inflammatory carcinoma. Inflammatory carcinoma is highly malignant. Okay, this is another type called medullary carcinoma. It is of the lobules. It's an invasive type carcinoma, sorry. This is a mucinous carcinoma. You can see the mucin. There's no cells here. It's just mucus, and you can see the carcinoma nest. You can see the cancers. Okay, so that's it for breast cancers. Hope you understood this.